Good morning. I'm Bonnie Gon-Bailey. Welcome to the Florida Health Grand Rounds. I am pleased to serve as the administrator over biomedical research at the Florida Department of Health. We are excited to restart our series on public health research findings, and they'll provide new information for department employees on research findings and resources that we can all use for our public health practice. This month, we recognize Healthy Brain Month. The department's biomedical research section has compiled healthy brain resources for your review and use. On the screen, you can see the Healthy Brain website. There you'll find posters and other informational tools in both English and in Spanish, and other resources, including the Healthy Brain Roadmap. CDC continues to release new and very interesting healthy brain information that is geared toward community use. If you do not receive their notices via email, I encourage you to go to cdc.gov and explore the Healthy Brain initiative and sign up for emails. Today, Grand Rounds focuses on a research study that is sponsored and funded by the Ed and Ethel Moore Alzheimer's Disease Research Grant Program. This program is implemented by biomedical research within the Department of Health. At this time, I'd like to introduce Robin DeWalt, our biomedical research scientific advisor, who will continue with housekeeping and introduce today's speakers, and thank you so much for joining us again for Healthy Brain.
Hello, everyone, and welcome. A few things to know before we get started with our seminar today is that all phone lines are currently muted and will remain muted throughout the entire talk. We will have a question and answer session at the end of the seminar. Please enter your questions into the chat function within GoToWebinar, and we will read those to our presenters at the end of the seminar. For your convenience, the slides from today's presentation will be made available at the department's website as soon as tomorrow. And we are offering 1 hour of continuing education credits that will be made available to those who attend the seminar today. In order to obtain CE credit, you do need to complete a survey that will be prompted automatically at the end of the seminar. And this survey needs to be filled out and completed by 2 weeks from today, or September 29th, in order to receive credit. You will also receive an automatic email within a week reminding you to take the evaluation survey to provide us feedback. And if you had already taken the survey, just please disregard. So Public Health Research at the Florida Department of Health is pleased to welcome Dr. Linda Kotler and Dr. Catherine Striley today. Founding Director of Health Street, Dr. Linda Kotler, is Associate Dean for Research in the College of Public Health and Health Professions and Dean's Professor of Epidemiology at the College of Public Health and Health Professions at the College of Medicine at the University of Florida. Before moving to the University of Florida, where she chaired the Department of Epidemiology from 2011 to 2018, Dr. Kotler was at Washington University for 30 years, including work on the landmark Epidemiologic Catchment Area Program, earning her PhD and developing a research program resulting in 30 years of continuous funding from NIDA and other institutes. This research includes development of culturally reliable and valid measures for identifying substance use, abuse, and dependence, along with psychiatric disorders and their risk factors. Innovative methods for conducting national surveys of high-risk behaviors and community-based, peer-delivered interventions to change high-risk behaviors and substance abuse. Dr. Kotler's research has focused on giving a voice to underrepresented populations and reducing health disparities. Her work has had international focus as well, extending to Australia, Taiwan, India, Kenya, Afghanistan, and Haiti, and this includes a Health Street location and Chulalongkorn University in Bangkok, Thailand. Dr. Kotler developed Health Street in 1989, utilizing a storefront location and community health workers to perform outreach. They assess health concerns and the needs of the community members and provide referral services as appropriate, as well as educate the community about research participation and link them with opportunities to participate. With outreach in most counties in Florida, more than 11,800 community members have been assessed, resulting in more than 24,000 referrals and almost 53,000 services provided. More than 2,500 members enrolled in relevant health research. Dr. Kotler is Director of the Community Engagement and Research Program of the University of Florida Clinical and Translational Science Institute. She also serves on the Board of Directors of the Association for Clinical and Translational Science and is the co-chair of the Special Interest Group PACER, Partners for Advancement of Community Engaged Research. Co-director of Health Street, Dr. Catherine Woodstock Striley, is an associate professor at the Department of Epidemiology of Florida Colleges for Public Health and Health Professionals and Medicine. She is also the program director for the Master of Science in Epidemiology and the Certificate in Psychiatric Epidemiology programs. Dr. Striley has worked in the community through the Health Street model since her postdoctoral fellowship with Dr. Kotler at Washington University in St. Louis, beginning in 2002. She received a Master of Social Work in 1989, the Doctor of Philosophy and Social Work, and a Master of Psychiatric Epidemiology in 2004, all from Washington University in St. Louis. She has been a co-investigator on many community-engaged NIH-funded studies conducted by Dr. Kotler among community members, out-of-treatment drug users, and women in the criminal justice system. She's worked as a clinical social worker and program developer and manager for a decade prior to commencing a research career. She is committed to researching hard-to-reach and underserved populations through paraprofessional and peers who are culturally appropriate and trusted members of their own communities, to the importance of screening and education to make sure people get access to the medical and behavioral health services that they need, and to reduce stigma for behavioral health problems. She has also been funded by several foundations to conduct research among people with Tourette's disorder, essential tremor, and substance use disorders. Dr. Striley currently teaches population health and medicine, psychiatric epidemiology, and research ethics for population health and mentors PhD and MPH students, as well as undergraduate students. Welcome, Dr. Kotler and Dr. Striley.
Thank you so much. We are delighted to be here for the launch of your series. And we do want to, I want to try to get this, there you go, thank you. Yes. See if we can advance this, okay. So today we're going to talk about precision public health approaches to reduce disparities in memory disorder screening in rural minority communities. And we really want to appreciate the Department of Health and the Ed and Ethel Moore Alzheimer's Research Disease Program. And Dr. Striley and I are partners in Health Street, and we're partners in this effort. And there's no more important time than right now in terms of our approaches with older adults. What we know right now, the world has changed since March with COVID-19, where there's been this pandemic, with the World Health Organization calling it this pandemic, and older adults are really, they are a focus of our attention even now throughout this time. So with our funding, with this pandemic, we are still forging ahead to really reach those people who need us the most. So we really do want to thank the Florida Department of Health for everything that they're doing and everything that they're allowing all of us investigators around the state to do for our seniors. It's a little bit difficult to advance the next slide. Let's see if I can do it with an arrow. No. Okay, so we're going to start with a framework of community engagement. And without the community, we have no engagement. We have to give everyone a voice. Usually people go to the agency directors or providers, which is okay. But we think of the tip of the iceberg, and we think about the people who are not being able to have a voice in the research enterprise and in the system, the learning health system as well. So one way that we think about this is to know that we have to gain the trust of our community And really, trust is a matter of our character. We're trusted because of our way of being, not because of some fancy polished exteriors or expertly crafted communications, but who we are. And so we have Health Street, a community engagement program to reduce disparities in healthcare and research. And that's what we would like to talk about today. Our model has 4 pillars. The first is assessment, the second is linkage to care, the third is bidirectional education and workforce development, and fourth is because of these things, we hope that we're building trust in our community. I'm trying to move this along with my mouse, but it just doesn't seem to go. Okay, we're going to first talk about assessment, screening for conditions and concerns for better health and targeted interventions. So our health needs assessment is something that our community health workers do. And they talk to people in the community where they are, and they ask a series of questions that really go from head to toe. And we're doing this so that we can have really good increased representation of all populations. And we're talking about social determinants of health, as well as coping strategies and their interest in different research. Our flow chart here shows the participants that we have engaged in since November of 2011. So we have about 14,500 people we've spoken to, and there's about 12,300 people in our database who have consented to being interviewed with that assessment that I just showed you. And we've completed the assessments on about 12,000 people. And we're going to talk about the people that are in our registry, in our cohort, in our database, and give you a little understanding for the kinds of efforts that we do. We have been throughout Florida, mostly in the north central corridor where we are in Alachua County in the darker rust color. And we do have community health workers who have gone throughout from Levy County, Marion, Putnam to Duval County, as well as work that we're doing in the Panhandle, Union County. And we also had some work going on in Miami-Dade County. Our demographics are shown here, where we have about 60% female. We have about 60% who are Black, African American. We are in the rural areas. About 7% of our registry are people who live in rural areas. We have a very high rate of current smoking. About a third of the population says that they smoke currently in the past 30 days. And high blood pressure is also something that is very important and a very important demographic and characteristic of our population. We ask people at the very beginning of our assessment, what are some of the concerns you have and what are the conditions? This particular slide shows the conditions that people report. So we're seeing here, they're reported female in the lighter blue and males in the darker blue. So you can see the differences by sex with all of these different conditions. But we do have a high proportion of people who have allergy, dental problems, hypertension, as I said, digestive health, headaches, sleep issues, skin problems, muscle and bone pain, and mental health problems. These are the reported concerns by the people in our registry, where they're mostly concerned about hypertension, males and females both, diabetes, pain, their weight, their heart problems, and cancer, dental, and mental health and vision concerns that people have. So when we're looking just at our older adults, because we do have a cohort of older adults, those are 60 and older, we have 3,184 people in our registry. About 2,700 people have consented, and we've done an assessment on about 2,600 people who are over 60. Many of these people were in our registry because we focused on them through the work of our Department of Health studies. And so we will talk more about them in this time. And these are the diversity for the older adults. So you can see high blood pressure is much higher in the older adults, 59%. But still, 18% are smoking currently. 44% of our cohort is African American, 62% female. These are the concerns of our older adults: hypertension, pain, diabetes, heart problems, cancer, arthritis, vision, weight, and dental problems that you can see here. And I'm sorry, but I'm just having a tough time with this. Maybe I can do this. Let me try this. No, that doesn't work. Okay. So we're going to talk now about the Etta Ethel Moore Alzheimer's Disease Research Grant Funded Project, which is to assess community members for cognitive impairment. We want to link them to memory clinics or to treatment and develop this registry, and also train physicians on the best practices for mild cognitive impairment and dementia treatment in 8 rural counties with high Alzheimer's disease mortality, working in partnership with Florida State University and Alachua County. So with the previous Etta Ethel Moore grant that we had, we were also going to link people to memory clinics and treatment, but we found out that you can't just link the public to a memory clinic or treatment without the physician. So that's how we came into partnership with this project, and to develop some kind of educational opportunity for physicians who might find it difficult to talk to their patients about cognitive impairment. So this is the project here. This is our the members who are 60 and older from our target counties and those with all counties. And we can see that pretty much we have this similar demographic, except for the target counties, we have fewer African Americans, and we do have pretty much similar demographics compared to all counties. We're doing the Montreal Assessment Scale, the MoCA. Kathy, good luck. In our registry of 2,581 people, we have navigated about 1,460 people to research. We've enrolled 633 people into studies, 43%. And for each one of these, we have trained our community health workers out in the field to do the MoCA. This is the Simple Montreal Cognitive Assessment Scale that's talked about in popular press. It's a very quick determination of cognitive impairment. And this, we're also doing an Alzheimer's disease knowledge and research interest questionnaire to really look at what people perceive and what they know about Alzheimer's disease. And these are by different quarters for our different time points with our Etta Ethel Moore. So if you just look over at the total, we have 418 people who completed this questionnaire, this perception, and we can see what the score is out of 13. They scored 8, a little over 8. You can see their education and their interest in research. People do have a high degree of interest in doing research. Okay, so now what I wanted to do is just introduce this topic so that Dr. Striley can talk to you about what's been happening here with the time during the pandemic. So we have epidemics happening all the time with hypertension, diabetes, mental health, and on top of this then was the pandemic. And so when we were socially distancing here at the University of Florida, as around the state, and our community health workers could not go out into the community, we had to figure out what are we going to do quickly. So we quickly changed our focus. We scrambled to get phone service to our community health workers. We assigned different cohorts to our community health workers. We applied to our human studies, our IRB, for revised protocols to allow us to have access for a database remotely. And we developed a short reconnect COVID survey for all of our participants. So Kathy, you can take over the controls and talk about the reconnection campaign.
Okay. I'm going to assume it's going to take a second for that change to be made, but I don't, because I don't see the controls right yet. All right, well, I'm going to just start talking. Oh, there they are. Yay. Okay. Yeah. All right, so this just gives you a timeline of our activities in reconnecting. And as Dr. Kotler said, we wanted to pivot and accomplish two things. One, we wanted to continue our work in the community, and we especially wanted to continue this at an Ethel Moore funded project all over, but we knew that we were constrained. So we were able to get permission for two things. Number one was to do our basic assessment, and number two was to do the MOCA. So we were given permission to continue to do that. On the other side of this continuing to be with our community, we wanted to continue to reach out to the people that were already in our registry and already members of Health Street. And again, as Dr. Kotler said, really find out what was going on with them during this period. So luckily, our institutional review board was able to approve us doing that. And you can see here the progress of our Reconnect campaign, going back to the people that we've already done a baseline on, and in some cases reconsenting them, and in some cases when they were over 60 years of age, conducting the Montreal Cognitive Assessment either via Zoom or via phone. You'll also see from this that at the same time we were allowing drive-up services here in Gainesville, and we know that doesn't reach the total population of Florida, but we did want to make sure that we had food available, which we were able to do through a community coalition here, including Working Food, and we wanted to make sure that we were still able to give out those resources and referrals that we could to people who came and drove up. And this just gives you some idea of cohorts, and this is just for the presentation of this data. We wanted you to see that we have these different cohorts, including this resource for clinical, for aging research, and then our DOH registry. And so those cohorts do differ in their age breakdowns. And we wanted you to see, especially following this DOH cohort and how they responded. On this survey, this sorry, rattle some papers here for a second. On this survey in which we were getting some of their needs, we had 5 different data domains. We already knew their socio-demographics, but if anything changed on that, we were looking at what was going on with their response to COVID and whether they had wanted to be tested and been tested, their health conditions, if they had a new cancer diagnosis, for instance, mental health, loneliness and stress, and anxiety, and structural needs. We've been tracking food insecurity, access to medications and internet, because those have been so important to us all, their health concerns and other needs that they saw in the community. This just gives you numbers and shows that some people haven't been reached. This is divided by whether the person self-reported being African American or not. And you can see that we have completed 1,258 among people who didn't say they were African American, and 1,099 among people who said they were. And again, in these different cohorts. So in the contact of attempts, we just wanted to let you know that you have to reach people over and over. We reach people, we try to reach out a total of, an average of 6 times before we consider somebody to have even been attempted to reach. So As you can see, it does take some time to reach people. I don't know about you, but I'm certainly screening more calls now that I'm at home more. And this again is those 3 piles: not reached yet, reached but survey not completed, and completed. This is for all of those cohorts. And you can see that very similar, but a little bit older in terms of the people who are completed, and a little less African American. And we also look at trust in research. And researchers, 2 of the things that we track all the time. We want to see the impact we're having, as well as just what's happening in our community. And working for DOH or being associated with DOH, I'm sure you're quite familiar with how important people's trust is, and this is on a 10-point scale. So testing, how many people tried to get tested, how many people got tested and were positive. We had in our sample a rate of 4% positive, and you can see that there was about 3 to 4% of people who tried to get tested and didn't get tested, a little more in the non-Black didn't get tested that wanted. This is, we always ask people, was there anything else you needed? Anything else we could do? So these are people's open-ended suggestions as to what else Health Street could be doing to help meet their needs in the community. And again, this is divided by whether they were African American or not. And, you know, the majority either said no, nothing else, or said keep doing what you're doing. There were a sizable portion, 1 in 4 in both groups, 1 in 5, who said, you know, can you do something else to minimize the threat of COVID-19 to us? So obviously that's on all of our minds. Food here, 8% in both groups. And really that educational component, about 1 in 10, a little more than that, are asking for more education on COVID, and our community health workers do provide that when they can. Then turning to just our older adult cohort, again, we reach a few more, a little bit more older, a little less African American, about the same Hispanic, a little bit more educated, and a little bit more that use social media. The trust in research is still about the same rate, about 7.5 out of 10. And again, looking at who got tested versus who wanted, this is pretty striking. Dr. Kotler was talking about the pandemic on top of the epidemic. And here we see that among those older African Americans who were tested, 9% were positive versus 1% in those who said that they were white or non-Black. And more people were getting tested. Here the lag is only about 2% wanted to who didn't get tested. This just shows you by time period. And the only thing, a couple things I wanted you to see here is that the people who wanted to be tested, of course, have increased over time. And also, you know, because it's basically a different cohort each time, we're reaching different people in our DOH registry, in our Florida registry here. You can't really compare these numbers, but you can see, if you look especially at this food insecure, you can see that at its lowest, it's about at this 20% range, and in some cohorts it's been as high as 42%. And then if you look at the medications also, even our total is 86%, we're able to get that medication. And when you think about that these people have multiple health conditions, that's a pretty significant number that aren't able to get all of their medications.
Kathy, can you go back?
Mm-hmm.
I think this is important for Department of Health and for the Ed Ethel Moore project. Look at the second row, tested. And you said before, try to get tested, went up, but look at those who were tested. It really went up. And although we have not very many positives, period 9, we have 8.7, 7, and 11%. That's only 2 people. But when you look at those who are really being tested and going up so high, and then the positive results, this is something that's really concerning to us. Sorry.
Another thing just to point out on this, since I did go back, is this 71.9% total who have internet at home. Again, this is that older group. So with telemedicine and some of the other trends, that digital divide we are very concerned about. So this is suggestions. So again, that idea of, is there something else we could do? Sorry, skipped one. This is concern. So are they concerned about anything during COVID? We always assume COVID will come to the top, but if you can see in this African American side, it wasn't at the top, it was actually second to hypertension. And we, as long as we've been doing this here since 2011, hypertension has been a real large concern in our community. Muscle and bone pain as well. And you can see that in both groups, and diabetes also, where we have a small paper I hope will be coming out soon that just shows that diabetes, even in a COVID time, remains a very significant concern in our communities. And here's the one that's suggestions. So again, this is with the older population. And here you can see, they're still looking for some education. They're looking for some resources, and testing popped up here, and food. We had food on the others, and now testing. So what do we do? I'm gonna summarize this at the end and say that one of the things that we do is we do social prescribing, but we link people to whatever they need. Our first priorities are always medical care, get them where they need to be. In this DOH, in this Ed and Ethel Moore grant, we're trying to get them to their primary care physician, so that physician can get them to the care that they need in terms of a memory clinic. And we also just want to meet whatever structural needs they're having, whatever social needs they're having. This is, again, our whole cohort, so not just the older cohort, but the whole cohort. You can see we're giving about 3 referrals to people. And then we call them at 120 days to see, were you able to go? Do you need other referrals? We try to stay in touch with people as much as we can without being overly invasive. And we do have a newsletter, and please let us know if you are not receiving that newsletter and want to. You can see that people's satisfaction with those referrals is pretty high, 3.6 out of 4. And what did we give? Again, we prioritize the medical and the screening needs. Dentistry, dental care is always high. Food, again, something we're really watching and really trying to work to help solve. Behavioral health also. But then tailing off into just all the needs here. And you can see housing, and we expect that to go up, of course, because of the trends that are happening. Now, just among older, again, about 4 referrals, utilization rate about 26%. We're trying to get that up. We're working on we have a couple things in the works to help people remember. And again, satisfaction's pretty high. Now here, dental popped over medical. So there's a real need, probably having to do with being older and having some additional needs for dental care. And then food is number 3. This is by MoCA. So really looking at the people whose MoCA score was less than 26 or greater than 26. And again, this isn't all of the people that had a higher MoCA score. But these are the ones that were wanting some kind of a referral, and again, you can see that among that group, the need still for dental care is pretty high, and medical care, and food popped up to second there. Again, these are the quarters that Dr. Kotler showed before, but just showing you how many MoCAs we're doing, and we are doing. It depends on the week, but we're doing MoCAs on the phone every week. We have community health workers that are focused on different communities. And you can see this bottom line, this bottom row is the 199 people out of 313 who scored in a range on the MoCA that would indicate that additional screening would be helpful to them. So to summarize what I just presented about social prescribing, yes, we do prioritize medical care and screening and getting them to mental health to memory disorder screening, but we also know that all of their needs are important. We try to be very holistic and make sure that we're sending people to meet the needs that they have. And there's a lot of evidence that's emerging that shows this kind of social prescribing is very important to people's health. So back to our pillars. Our bidirectional education and workforce development. As a part of the Ed and Ethel Moore grant, we wanted to increase the capacity of primary care physicians to link people to memory disorder clinics and to understand Alzheimer's disease and other dementias and get over some of their concerns. We know there's a lot of literature that supports physicians being worried that it will rupture their relationship with the person who's their patient if they bring up the need for screening. So based on that, we got some experts together, and the Alzheimer's Association also have endorsed this. And they presented a CME that's available for free for anybody who wants to sign up for that. And sorry, little noise here. And in that CME that was hosted by Dr. Maraganore, they really talk, just really briefly, it's only an hour long, but about how to talk about Alzheimer's disease and decline, how to know as a physician when you should refer. And if you see from, let me see, that one didn't want to go now. There you go. Oops. These are questions that are addressed in that brief hour-long presentation, really quite a lot of questions. And we continue to get quite a few people every week who take that. We had some low rates at first just because we had a problem with how our registration was working through our CME. They didn't think it would be a problem, but it was. And we have in our community, Our Health, which we live stream to any place that wants to take it. We'd love departments of health to take advantage of that. It's always good experts in the field with an interactive, really the whole part interactive so that people can ask questions via text. This was one on distracted driving, especially relevant for older drivers who might be experiencing some functional decline. And I'm going to turn it back to Dr. Kotler to talk about trust if I haven't stolen all her time.
Not at all. Maybe I can do the thing like you did it, because that's just not coming up on my screen. Yeah, I don't see those clicks that you have. Anyway, I want to say a couple things. I wanted to emphasize a couple points that Dr. Striley made. One was the CME, that we really appreciate DOH. This was part of our grant. And so this is available to anyone, and it is at no cost. And to get a CME at no cost these days is really great. So any physician in the state who would like to be getting CME for taking the Alzheimer's disease, the cognitive impairment training, please reach out to us. The other is about social prescribing, which is really a new thing, a new word for us, because we've been doing this for a while, where our community health workers have a little, like a prescription pad, and they'll write down, go see, go to the park and, walk 10,000 steps, meatless Monday, drink water, go to the vision clinic here, it's free on Mondays, go to free mental health nights on Tuesday, whichever thing that there is, they write down, they give it, they track it. I mean, we have, the old fashioned form where there's a form on the bottom of it that captures what they gave out. And then we track all of that because, as Dr. Striley mentioned, we call it 60 and 120 days to see what referrals people took advantage of and which ones they did not. And if they took anything they went anywhere on their own. So the social prescribing effort initiative is really becoming a big thing right now in communities. And then, as Dr. Striley mentioned, our community, Our Health, we would love for you all, Department of Health, to carry our OCOHs. They're usually on Thursdays. They're from 5 p.m. to 6 p.m. Some of them are streamed, I mean, all of them are streamed nationally, but some of them do have national partners. But anything you would all like to have as a topic for an OCOH, we would love to help support that with you. Okay, so back to the question about building trust, to measure perceptions and trust, to break down walls. We do ask this question about trust in research and trust in researchers. On a scale of 1 to 10, where 1 is no trust, 10 is complete, how much trust do you have in research? And how much trust do you have in researchers? And what we've done here is to look at all the data for all of our Health Street registry. And at the top right, we have the concordance between high trust in researchers and high trust in research. And you can see here that about 45% of our members say that they had high trust in both, which meant high meaning they scored over here. You can see 1 to 3 is low, 4 to 7 is medium, 8 to 10 we said was high. So 45% of them have a high score, whereas 5% have low trust in both. And it's these people that we want to try to really focus on to find out how can we increase their trust in research and in researchers. And here we have the people who have medium in both. Those are also people that we want to, intervene with. These are the registry of older adults who have even higher trust in research and researchers. So that's amazing what our seniors or the people that we have in our registry, what they feel about research and researchers. And that about 5% also have low trust in both. So that when we really do talk with them and we try to understand what their needs are, we really have to take this into consideration. Okay. Now, this is a slide looking at those who have high in both, in low, medium in both. And then we look at their interest in research participation. And as you would expect, those who have low, they have the lowest interest in research participation compared to those who have medium or high. So those with high trust in both, they have the highest interest in participation. And we asked them very specifically, what kind of research would you be interested in? And you can see that for every single one, their interest level, their willingness level goes up if they have high trust in both. So that but you also can see how high their willingness is. Whereas some of the things over here are lower, like if they had to stay overnight, or if they had to use medical equipment or take medication. But when we look at the navigation, those two, when we navigate people based on when we look at their trust scores, as you would imagine, those who are navigated to a study, they increase in their willingness their ability to be navigated based on their trust scores, and enrollment also. But when we look at that among those who were enrolled, among those that were navigated, once we were able to navigate someone, it flipped. That those who had low trust in research and researchers, they had a higher rate of enrollment. And we think it's because of the amount of effort that our community health workers are having and doing with our participants. Somehow, let's see if I can take your thing off. There you go. Okay, these are our partners. So in building trust, we also work with our safety net partners. We put them on our calendar every single month so we know who we're going to be meeting with at Health Street, and with all of our programs and with our food pantries, and we do meet with the safety net. And we have a community advisory board, and we do have older adults on our community advisory board as well, who are very connected to some of the programs here in our area and elsewhere, who represent these stakeholders throughout Florida. And we do have some chosen by Florida State and some chosen by University of Florida, both in Gainesville and Jacksonville, and around the state as well. And we rotate these meetings 4 times a year. So in our looking ahead, final slide, we're saying that we really do, we will continue to focus on our assessments and really continue to assess our needs and conditions and compare those by age, by race, by gender, and using these data to bring needed help to the areas that really need us the most. We also will continue to link to services and research, increasing our social prescribing, integrating with an expanded range of community serving groups, promoting the utilization of community health workers who really are going to be working in this CEAL, the SEAL program in Florida, looking to really, in terms of COVID, trying to get the messaging out, trying to reduce disinformation. This is so important for us to deliver these messages through trusted people in the community. And linking our Health Street members to add the social determinants of health into their medical records if they have one, because physicians don't have information about the number of people who they live with, or some of the coping mechanisms that they have, or their loneliness or their stress scales. And then in terms of bidirectional education, we really want to utilize our community, our health more broadly, and wanting all of you out there listening to help us, think of people that topics for us. And then in terms of building trust, as we said before, we want to have some kind of a predictive algorithm so that we can say at the beginning, when people say they have low trust and they score low, that we can help them and maybe we know that we have to do more for them for the future. So here we are right here. We really humbly acknowledge all of our community engagement partners and Health Street faculty and staff, all of our members, and the Clinical and Translational Science Institute, and especially the Department of Health, the Ed and Ethel Moore Alzheimer's Disease Research Program. We'd like you to join us on social media at UF Health Street, and really do appreciate all of your interest and all of your attention today.
Thank you so much, Dr. Kotler and Dr. Striley. At this point, I'm going to switch over to our Q&A and go to our chat. If anyone on the line has any questions for our speakers, please feel free to send them now and I will read them. Okay, just one moment here. Okay, first question here. What is your experience in the stress caused by COVID and its impact on the memory changes? Memory disorder clinics are not always found in rural areas. What are some other options?
Yeah, Dr. Striley.
So we don't clinically track what's going on with memory to the point where we would see on an individual basis the effect of the pandemic on that person over time. We're checking in with people, and in our Reconnect campaign, we're gonna talk to people one time. So we would at the most have basically, let's say 4 shots because we'll have the 60-day follow-up, the 120, and then the pandemic, the Reconnect during the pandemic. And we're not really doing separate MOCAs. We're just doing one MOCA with person. So I apologize, I can't really answer that question. In terms of stress, though, we are seeing an increase in stress over time with people in the pandemic. Our scale is 0 to 10, and we're seeing people that are scoring 7, 8, 9, 10 in stress, which we think is pretty high. I don't know about you, but when somebody asks me about stress, I seldom answer something that high. So we really, you know, if you think about somebody who's isolated and maybe doesn't have internet and maybe is not getting all their medications or struggling to get their medications and having trouble with food, we know that loneliness and all of those structural issues are really going to have an impact on the way that they're processing information and their cognitions. In terms of rural areas, we know that is a problem, and we've had some DOH counties express some concerns about, you know, trying to get people from their county to a memory disorder clinic because they're not always easily accessible, especially for people who are older and have transportation difficulties. You know, that's one reason we're really focused on primary care physicians. We know that those primary care physicians know their community and know the places, the specialists, and know the places where people can be referred for additional care. And so, you know, again, we're really wanting to get as many primary care physicians in those rural areas in Florida to get educated and to continue to get educated. So that we can make a difference there. We do, again, because we're going back to people and we're saying, do you need additional referrals? We know we are able to track and see if that falls through, if they're not able to get help from their physician. So as time goes on, we will have more information to report back to you about that.
I also think this is a really good point about the MOCA being done over the phone, over Zoom, that we never knew we could do before, but Dr. Striley has had training in this, and I think it's also good for providers to understand the length that they can go to with their patients, and that they could offer such a service to the patients. And the other thing that Dr. Striley mentioned about stress, loneliness, depression, anxiety, we have all of these measures, and it would be great for us to look across the board to see who has a high in stress and a high in depression, anxiety, and a high in loneliness. Those are the people that we really need to reach out to on a maybe more frequent basis. But that's just gave me a great idea for an analysis to look at.
We also track social support at baseline. So we ask if people have concrete kinds of social support, somebody who'd help them with getting something, if they have emotional social support, and we ask them about their satisfaction with the support that's around them. So we also know that and can compare that with loneliness and depression, anxiety.
Okay, great, thank you. Another question we have here is regarding the high rate of smoking. Are you referring to Tobacco-Free Florida with help of quitting? And if the person has smoked more than 30 packs a year, are you referring to lung cancer screenings? And can you comment on the willingness of those older smokers to get the help with quitting or interest in lung cancer screenings? Thank you so much, by the way.
I will just say that we have found it difficult to get people to sign, well, maybe they sign up for the smoking cessation program, but we have found it difficult, as other safety net providers have found it difficult to keep them in the program. We also see high cancer rates in these same areas where there are high smoking rates. And this is a big problem for us here, what to do about it. So it's a problem when we see something and we trying to do something about it, but it's very difficult. So anyone who has ideas, we would love to have it, but we are referring people to all the Department of Health programs. Dr. Striley.
And we have tried to get funding for getting people more lung cancer screening too, and for just alerting people if they have that 30-pack life smoking history, that lung cancer screening is recommended. And so our community health workers are trained to help people know that, and to say to them, they have kind of a little algorithm that they go through to say, you know, we would really like to refer you to get some lung cancer screening, and here's why you need it. So providing them with some educational material too and background about why to do that. But again, we're as frustrated as everybody else with all the making sure people do follow up, but we think our community health model works, And we think getting community health workers paired up with people will work, and to get them into lung cancer screening will work, but we haven't been able to really set aside the kind of resources that we need to do that without additional funding.
Okay, great, thank you. That concludes our Q&A for today. And I wanted to remind everyone on the line that our next presentation will be on October 13th at 10 a.m. This will also be a virtual seminar series, and announcements will follow the meeting. As a reminder, there will be an evaluation when the seminar concludes today that will be automatically prompted to receive CE credit. Please complete that survey within 2 weeks. This presentation will be made available on the Department of Health's website at our Grand Rounds website and can be viewed at a later date. I want to say special thank you to our presenters, Dr. Kotler and Dr. Striley. It's been wonderful to have you today. We have enjoyed your presentation, and thank you so much for joining.
Thanks for giving us this opportunity.
Yes,
Okay. Thank you so much. Everyone have a great day and stay safe.
thank you.
Thank you.